as such, where we know speech is produced by action of multiple systems, right from the respiratory system, moving up to the laryngeal, the articulatory, and the resonatory system, with all of this being controlled by our box, the central nervous system. Now, the problem here lies at the level of the articulatory system and the resonatory system for individuals with cleft lip and palate, because of which there are speech deficits. Though the palate is repaired, I just told you a few minutes back, the palate gets repaired as early as 9 months. So despite the palate being repaired, there can be certain residual deficits which are there in the structure, which contributes to speech problems in individuals with cleft. Some of the common abnormalities or the physical factors that can contribute to speech problems are there can be residual dental, there will be dental anomalies, like there can be alignment issues of the teeth, there can be overcrowding of teeth or sometimes missing of teeth, many of these dental issues which we know can contribute to speech problems. There can be residual cleft by itself. Like, for instance, a cleft in the alveolar region, the alveolar ridge region, is not corrected till the child is around 10 to 13 years of age, when the procedure called alveolar bone grafting is done. So till then, there could be a residual alveolar cleft. So there could be presence of residual clefts. Sometimes the cleft is repaired, but still there is a breakdown of the surgical intervention, resulting in what we call as fistula. And very often, the other common culprit that we see in individuals with cleft is this condition called velopharyngeal dysfunction, wherein the velopharyngeal port, which is, if you look at this part here, this is the palate here. And so the palate, we all know, has to move towards the posterior pharyngeal wall, resulting in a closure so that air pressure, oral air pressure, can be built up. Now, in individuals with cleft lip and palate, though the structure might look fine, the function of the soft palate in terms of moving against the posterior pharyngeal wall and making a complete closure might not take place, resulting in velopharyngeal dysfunction, which also could contribute to speech problems in individuals with cleft. If all of these are the physical factors which are contributing to problems in cleft lip and palate, the other biggest culprit is the learning factor. Children sometimes learn maladaptive strategies to compensate for the presence of cleft in the very young age. And as a result of that, they produce a lot of compensatory error patterns, which persist even after the palate is repaired. So we play a major role in helping them correct these learning factors. The errors because of learning factors are what we as speech pathologists are trying to correct. This is something we need to understand right in the beginning itself when we're working with individuals with cleft lip and palate. A person with cleft lip and palate can have a combination of errors, one set of errors because of certain physical factors that are involved, and another set of errors which could be because of the learning factors. As speech-language pathologists, we should be able to differentiate these two categories of errors. Now, why is it important for us to differentiate between these two categories of errors? It's because the management strategy differs completely. Speech therapy cannot correct a structural deficit. Speech therapy is used to correct the function of speech. So we as speech-language pathologists will be able to bring about a change only when structure is taken care of. So when physical factors are contributing to speech deficits in individuals with cleft, we need to make appropriate referrals for correction of those physical deficits before we take them in for speech therapy. So this is something we need to differentiate, and this is probably the ground principle on the basis of which cleft speech therapy will work. And I'm sure this is the case with any other structural anomaly as well. If there is a structural deficit, we need to do something to take care of the structure first. Either correct the structure or look at providing some prosthetic device to compensate for the lack of the presence of structure, and then take care of the function of speech. So this is a ground rule that I want all of us to keep in mind as we go through this presentation as well. So now that we understand why we see speech errors in individuals with cleft lip and palate, we'll move on to see what are the manifestations of speech errors that we can notice, or how do we classify the speech errors in individuals with cleft lip and palate. So if you look into the components of speech, all the ones that are marked in blue there are generally affected in individuals with cleft lip and palate. It's excepting fluency and prosody, almost all the other components can be involved to varying extent here. The most common problems we notice are problems in articulation and resonance, and there can also be a coexisting problem in voice because of the maladaptive patterns that they use. So these characteristics are very commonly, when we talk of cleft speech characteristics or cleft type characteristics as they are referred to in the recent days, there are 5 major characteristics that we look into. 1, atypical consonant production. That is, there are misarticulations or consonant production errors in the speech. 2, there is abnormal nasal resonance. So the resonance is affected. Now, I'm sure all of us here in this group know what resonance is. Resonance is something that is related to the quality of speech, which is something that is because of the tract that we have. Because sound is passing through the vocal tract, the vocal tract has its own resonance properties, and those contribute to a unique voice quality for each person. Now, when we all speak, majority of our sounds are oral sounds, which means the sound has to pass through the oral cavity and have an oral resonance to it. But what happens in case of individuals with cleft lip and palate is the sound, instead of passing through the oral cavity, slips and passes through the nasal cavity. And as a result, the oral sounds start getting a nasal resonance to it. So there is an abnormal nasal resonance, which is another characteristic which is commonly seen in individuals with cleft lip and palate. The third phenomenon is abnormal nasal airflow. Now, this is especially for the students out in this group. Please differentiate between nasal resonance and nasal airflow. The resonance is an acoustic phenomenon because of sound passing through a cavity. Now, airflow is it's an aerodynamic measure. You sense the airflow. It is to do with the dynamics of air movement. So airflow is different from resonance. Resonance is the quality of speech. It's an overall quality. Whereas airflow is something that we perceive specifically during the production of speech sounds, especially the pressure sensitive sounds are where we pick them up more commonly. So abnormal nasal airflow, which is what is called as nasal air emission or nasal turbulence in individuals with cleft lip and palate, is a phenomenon where when they are producing oral sounds, there is a perceivable escape of the air through the nasal cavity. That's your abnormal nasal airflow. So if you have to differentiate, just to listen to it. So somebody is saying, let's say, pa pa, this is the normal production. Let's say pa 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 is a normal production. If this pa pa is going to sound as this is a abnormal resonance phenomenon, and an abnormal airflow phenomenon is when you perceive it as ha 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 ha. You can really hear the airflow coming through the nasal cavity. So that is the major difference between these two in terms of your perception as well. And the principle behind which why these two occur is also very different. So you should really try and distinguish between these two features there. The other phenomenon that we can notice when people are doing these abnormal nasal airflow is there can be grimacing that you notice. So it might not just be ha, ha, ha that they do, but they do it with grimacing. It goes as ha, 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 with grimacing to different extent. It might be a very subtle grimace. It might be a very obvious grimace. I know of patients, I can show you some patients who can never speak or who can never speak, especially when you give them the pressure consonant, they go literally, banging their head forward and backward as an associated movement that is present along with their sound production, especially for pressure sensitive consonants. So nasal or facial grimacing is another characteristic that we see. And then the fifth characteristic that we would notice is altered laryngeal voice quality. By the end of the presentation, you will understand why we see altered laryngeal voice quality. So I won't dwell into that now at this point. So moving forward, we will try to look into each one of these characteristics and how each of this can be further classified. The best way to identify all of this is through a proper perceptual assessment. And when we have to do a proper perceptual assessment, there are three things which has to be present in it. There are three components in order to say that your perceptual evaluation is really meaningful and done in a reliable and valid way. One, you need an appropriate speech stimuli. Now, we all know that pressure-sensitive consonants are the ones where there is difficulty for individuals with cleft lip and palate. So a perceptual evaluation of speech should ensure that all the pressure consonants of the language are evaluated. So we need to have a speech stimuli designed in an appropriate manner that will help us elicit the pressure consonants in certain combinations as well. Then the next thing is you need a suitable recording tool and a reporting protocol. So the recording tool that is universally accepted these days is proper video recording. So you need a good video recorder and you need to follow a standard reporting protocol. There are plenty of reporting protocols available in the literature, but what is popularly used in India across most centers currently is the universal reporting parameters universal parameters for reporting outcomes in cleft lip and palate by Henningsen et al. In 2008. Now, this is an open access article that can be downloaded by anybody from the internet, and they have a very beautiful protocol for reporting outcomes or profiling speech characteristics in individuals with cleft lip and palate. And then the third and the most essential thing which we have to really invest time and energy in is training our auditory systems to be able to identify these cleft type errors. There are many common errors that students do in identifying these cleft type errors. For example, the most common characteristic that we see in cleft lip and palate is the production of a glottal stop. Very often, beginning listeners tend to misidentify the presence of a glottal stop as omission of a consonant. It is not an omission of a consonant, but it is a substitution with a production at a glottal level. So one has to tune their ears. Just as how we say our audiometers need calibration, our ears also require calibration, and we need to tune our ears to be able to identify these error patterns. So we'll look into each one of these. So when I say appropriate speech stimuli, there are standards available for how the speech stimuli should be designed so that we are able to identify the characteristics. And this is a very important part of the perceptual evaluation. So a comprehensive speech stimuli is important. And when we say a comprehensive speech stimuli, it should include a general conversation or a narration task that will give you a connected speech or a discourse level sample. Rote speech, which could be counting of numbers, telling the days of the week or months of the year or whatever, some rote speech component. Syllable repetition and repetition of phonetically loaded words and sentences. So the objective is that you have linguistic stimuli across different levels, starting right from the syllable onwards to words, sentences, and discourse. That is the objective in collecting a comprehensive sample. And the comprehensive sample also, especially when you're doing the words and sentences where you have a control on, you have to ensure that the words and sentences that you use are belonging to the pressure consonants in the language. So this is an example of sentences that are available for the Hindi language. So you can see that almost all the pressure consonants, we also do nasals because we want to identify if there is any hyponasal resonance. So you can see there are sentences for each of the sounds there. So pa has pappu papita pakdo, bahar bahut barish hui. So you can see that each of the sentence is loaded with one particular pressure consonant. And if you run through the entire list, you will be able to get information on how the production of all the pressure consonants goes on in the language. The next thing that I told you is a trained or a tuned ear or auditory mechanism. So we have to be able to identify all of these parameters. We look at the consonant production errors, nasal air emission or nasal airflow, the resonance abnormalities, and the voice quality. So we need to be able to listen. So from the comprehensive speech sample, we should be able to listen to each one of these components without mixing them up. That is the important part there. So in addition to these, the universal reporting parameters also talks of two global speech parameters, which are speech understandability and speech acceptability. The surgeons in majority of the teams just love this parameter because that's like a overall indicator of what is happening with the speech. But as speech language pathologists, for us, more than the global parameters, I would say the other parameters are important. The Cleft specific parameters are more important because that is what is going to help us in designing our objectives for therapy. Now, looking at how do we bring this out from the comprehensive speech stimuli? There is something called as structured listening, which is again a method that's discussed in the universal reporting parameters, wherein researchers have identified and say, when as speech language pathologists, you're listening to the comprehensive speech stimuli, try to listen to specific parts of the stimuli for rating specific parameters. The advantage of doing this is your reliability of record of your analysis improves. Because I know when I have listened to the conversation sample, I have rated speech understandability. The same has been done by another speech language pathologist as well. Likewise, when I listen to syllable repetition, I have only looked for the presence of nasal air emission or nasal turbulence in there. And the same thing is being used by another speech pathologist. So the reliability is increasing. So for structured listening, they say, using the conversation, speech, or narration task, listen and rate the speech understandability and acceptability. The rote speech and syllable repetition can be used for nasal air emissions and nasal turbulence. The phonetically loaded words and sentences can be used for consonant production errors, and the sentences for resonance. Resonance is always assessed in connected speech. While we come to that part, I'll explain why. And each of this has a specific rating scale as well. So as we go through each of the parameters, I'll explain the rating scale there as well. So the first and the most common error pattern that we see is consonant production errors. So I'll first touch upon that. So in case of consonant production errors, we can rate them both in words and the sentences. So the phonetically loaded words and sentences can be used for this purpose. And here, when we are doing this, what we need to do is identify the major characteristics that we see, which are the ones in bold. The most common pattern that we see is the first one here, where there is abnormal backing of oral targets to post-uvular space. That is, what happens is the oral sounds, be it p or th or k, maybe all the oral sounds or only specific oral sounds, moves backward. What happens in cleft lip and palate is the common maladaptive pattern is posterior compensatory errors. So the sounds that are to be produced in the front of the cavity moves backward. Now, why does this happen? If you remember, I told you the velopharyngeal port sometimes does not function well in individuals with cleft lip and palate. So when the velopharyngeal port does not function well, what happens is people tend to lose air pressure at the level of velopharyngeal port. So it becomes difficult for them to build the air pressure anterior to the velopharyngeal port. So because it's difficult for them to build it anteriorly, they unconsciously start building the air pressure before they lose it off at the level of the velopharyngeal port. So therefore, what happens is all the production sometimes moves posterior to the level of production against the posterior pharyngeal wall, or sometimes as posterior as the glottis. So what happens is papa will become Now this is different from is where there is a omission of the consonant. But what children with cleft do is there is a glottal adduction that they do. There is a sudden glottal adduction that they do. And this is what we call as a glottal stop. So when we are having abnormal backing of oral targets to the post-pharyngeal space or the post-uvular space, you can have them move either to the glottal and produce a glottal stop, or you can have them move it to the level of the pharyngeal and produce a pharyngeal fricative also, a pharyngeal stop or a pharyngeal fricative also. So that would sound something like ha, 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 where the back of the tongue is hitting against the posterior pharyngeal wall and they are producing the sounds there. So this is one common error pattern that we can see. Another error pattern is there is backing, but backing within the oral cavity. So a tata can become a kaka, or a tata can become a kaka. So it is not going as back as the posterior pharyngeal wall or glottis, but it's still getting backed. Now, this backing can occur at any level. It can either move to the velar level. We don't see so many uvular productions in our languages, or it sometimes moves to the level of mid-dorsum palatal. A mid-dorsum palatal is a sound like a tap on the palate. It's like, it sounds like that, where the tongue body is going up against the posterior, is going up against the palate and producing a sound, against a hard palate specifically. So what happens is all your front sounds, that is your th and t, can become, so it's like nature, able, torch. You hear a click at every time they produce a sound. That's another backing that can take place. Errors can occur in stops, which are the first two errors that we discussed. Then the third one is errors can also occur in fricatives. So the fricatives sound nasalized. The fricatives gets backed to the posterior level. Any of these can be noticed. So nasal fricative can be seen. Sometimes it's only one or two fricative that is affected. Sometimes all the fricatives in the language gets affected. So we need to watch out for that. So that would sound something like this. It will be 1, 2, 3, 4, where there is a backing. So what I'm doing is I'm producing the s with the back of my tongue against the posterior pharyngeal wall and also letting air escape into the nasal cavity. So there is a posterior movement, there is a posterior friction that I'm doing, and I'm doing it along with a nasal air escape. This can be seen. Or the other common error pattern, easy ones relatively to identify, are where they produce or where they substitute a nasal consonant for a pressure consonant. So baba can become mama, or dada can become nana, where there is a very clear nasal consonant substituted for the oral consonants. There can be nasalized voiced pressure consonants, or in general, what can happen is the placement might be beautiful. They can have very proper placement, but they become very weak. Any of these can be noticed. So these are the consonant production errors that we notice in individuals with cleft. Okay. So here I've just tried to pull out the consonant chart of the Hindi language, and what I have circled there are the consonants of the Hindi language. And in this, the consonants that I have listed in the first row here, circled in the first row, and the consonants that are listed in this row of fricatives are the pressure sensitive ones, which are most sensitive or which are most commonly affected in individuals with cleft lip and palate, the plosives and the fricatives. So whenever we use, we have to be sure that our test material includes all these plosives and all these fricatives in the assessment. And we also have the affricates also, which are pressure sensitive sounds. So these are the ones that should definitely be assessed when we are talking of consonant, identifying consonant production errors. So bilabials, not much of a problem if it is cleft of palate, but then from the alveolar retroflex onwards, what can happen is these anterior productions slowly moves to the posterior part. So it can move to as posterior as palatal production, or velar production, or the glottal production. Any of these can be seen. So bilabials can also be a problem at times, but the alveolar and the retroflex sounds moves backward and they go into the palatal, velar, and glottal zone. That is what we see in individuals with cleft lip and palate. I'll skip this part on the manner. So let's just listen to this sample, keeping my fingers crossed. I hope the video plays. Is it audible?
Serippu. Maadu. Amai. Nai. Mean. Kai. Mooku.
Listen to the curse especially. I've specifically chosen a word repetition task so that it's easy for people to identify. Listen, focus on the curse and try to see what's happening here is this child is moving all of those to the glottal production. So see whether you're able to appreciate the glottal production there.
Roja, Maram, Laddu, Puli, Sakkaram, Khas, Jannal, Unjal, Dappa, Aad, Bommai, Pambu, TV, Vattam, Tengai.
So you can see the bilabials are fine, but the moment you're moving to the alveolars are intermittent, and from the retroflex, almost everything is getting into the back position and it's going to the glottal production. So it's all coming from here for those productions. Now, this is another boy with consonant production errors. We will also be listening to the resonance of this boy later.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, now 61 to 70.
61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
So you see, all the sirs are actually getting stopped. And it is that even the sir is being substituted with a glottal stop by this boy.
1,
Now, this is another one who has majority of weak pressure consonants. You will be able to appreciate his placement for majority of the sounds, but placement is also affected for very few sounds. So let's just listen to this quickly. And
Papi, papi,
papi, papi, papi, papi.
kaki, 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 kaki.
Happy, happy, happy.
Tati, tati, tati.
Happy, happy, happy.
Sasi, sasi, sasi.
Happy, happy, happy.
Shashi, shashi, shashi.
Happy, happy.
अच्छा, अभी मैं जो बोलूंगी वो आप वापस बोलना है आपको, ठीक? पप्पू पपीता पकड़ो.
Papu, papita, patano.
बाहर बारिश हुई.
Par, mare, hui.
दादी दूध दे दो.
Dani, nu, neno.
टिक्कू का.
so you can see that the bilabials are fine, but beyond the bilabials, there is backing happening, but everything is not getting back to a glottal stop. Sometimes it's also a substitution of a glottal fricative that this child was doing. He was doing a ha sometimes, especially when he was doing his sasi, sasi, sasi. It was becoming a ha, he, ha, he. But I'm sorry, his sasi, sasi was tati, tati. So the placement was there for sir, but it was getting stopped with the alveolar stop there. And for sounds beyond that, it was getting back to the glottal production. So we need to be able to identify at what level this backing phenomenon is taking place, and we start working on sounds from there onwards, provided they are compensatory in nature.
पापी.
So how do we say? So when we listen to an error pattern, what is the next step that we have to do? So I first make a list of all the error patterns. And once I have the error patterns after listening to the child, the next most important thing is look into the mouth of the child. Do a proper oral peripheral examination, which will help us identify what are the structural deficits that we notice in the child. So the structural deficits will then will help us correlate between these two, and we have to see what is contributing to this speech error. So if we are finding a cleft related error, if there is a structural deformity that's contributing to the error. Like, for instance, you have a person who's not able to say the sir. And when you look into the mouth, you see that he has a little fistula sitting in the alveolar region. So we know that the fistula is what is contributing to his lack of production of the sir. So it becomes obligatory there. It is obligatory to the structural deficit. So once we identify the errors perceptually, we need to look into the mouth and do an oral examination to see whether there are structural deficits which are contributing to the error patterns. And if there are structural deficits contributing to the error pattern, we would classify them as obligatory errors. So velopharyngeal dysfunction, dental malocclusions, fistula, these are some of the common structural deficits that can contribute to error pattern. You don't see any structural deficit. There is a beautiful structure in there, but still the child is moving back, especially the back placements where the place of articulation is compromised. Those are what we categorize as compensatory errors, and those are the ones that we target when we take therapy for these individuals. So here is a child where you can see a range of structural deficits. So you can tell me and see whether you're able to appreciate the type of errors here.
Mangai, Manjal, Usi, Nool. இப்போ நான் திருப்பி சொல்றியா? பாப்பா பாட்டு பாடு. பாப்பா பாட்டு பாடு. இன்னொன்னு சொல்றியா? மாமா மாமி மக்கு. மாமா மாமி மக்கு.
So you could see the range of structural abnormalities there. There were abnormal dentition. There was a fistula sitting in the alveolar region. There was premaxillary protrusion to a certain extent. So all of these structural deficits are definitely contributing to the speech errors in this instance. So these are not errors that we would correct in speech therapy unless the structural deficit is being taken care of. So these are the common consonant production errors. The other pattern that we can see is presence of nasal air emission, which is, I already demonstrated it to you. There is a perceivable nasal air escape that can be noticed during speech production. And this is how it sounds when produced by a person with cleft.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay. 60 to 70.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69.
So you can see the placement is fine. There's no issue with the placement, but there's a very clear nasal air escape. Now that was nasal air emission. On the other hand, hypernasality, that is where there is an increased resonance in terms of in the oral consonants, sounds like this. So this is something that you test with your pressure consonants, and oral pressure consonants are best used in both high vowel and low vowel combinations in order to perceive resonance errors easily. And it's always, always, always important that resonance is assessed in connected speech. So this is how it would sound, a hypernasal speech.
உங்க நேட்டிவ் எங்க? சரி, இப்ப வேலை செய்றீங்களா படிக்கிறீங்களா?
இப்போ நான் ஸ்டிச்சிங் பண்ணுவேன்.
ஸ்டிச்சிங் பண்றீங்க.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
61,
61,
62,
62,
63,
63.
Operator, speech recording.
Another sample with resonance issues.
பி விவேக். நான் வந்து சைதாபேட்லேருந்து வரேன். எங்கள் அண்ணன் பேர் வந்து ராமகிருஷ்ணன். அவன் குருநானக் காலேஜில் பிகாம் படிக்கிறான். எங்கள் அப்பா பேர் வந்து என் பாலசுப்ரமணியம். அவர் இன்சூரன்ஸ் பண்ணிட்டு இருக்காரு. எங்கள் அம்மா வந்து ஹவுஸ் ஒய்ஃபு. ஸ்கூல் வந்து ஈநகரில் இருக்குது.
So if you listen to the sample, the English words, I'm sure all of you would have been able to pick up. I'm sure you would have been able to appreciate that there was no problem with the articulation there. The placement of all the sounds was perfect, but there was an increase in the resonance. That's hypernasal resonance. Sometimes just after surgery, or sometimes in cases of instances where there is excessive adenoids or enlarged adenoids, or if there are any nasal obstruction, sometimes we can have hyponasal resonance, wherein the nasal sound has lost its nasal quality. So the nasal sound sounds like an oral, then that would sound something like this.
Operator, speech recording.
பார்த்து உறுதிமொழி நாட்டின் ஒருமைப்பாட்டையும் உரிமை வாழ்வையும் பேணி காத்து வலுப்பட வேண்டும் என்று நான் வளமாற உறுதி கூறுகிறேன்.
Operator, speech recording.
So the hyponasal resonance is relatively easy to identify because it's like how you sound when you have a cold and when you have a blocked nose. That's how you're going to be sounding there. So when you find error patterns, we have to see whether there is any underlying structural deficits which is contributing. In case of resonance issues, you may see velopharyngeal dysfunction, which is contributing. We may see a fistula, which is contributing to resonance issues. So we need to look into the mouth to be able to identify this. In the case of BPD, that's a whole topic by itself. I will not touch into that today. We will have to do assessments to confirm the presence of velopharyngeal dysfunction. So what's important is you need to assess this entire thing based on spontaneous speech and the entire speech sample. When you want to look at your global speech parameters, you look at your global speech parameters and try to see for the presence of any voice. You look at the entire speech sample to identify deviations in voice and to identify your global speech parameters. For all of this, you need to listen to the connected speech sample. In the case of voice, we look for deviations in loudness and quality. This could be present because of the excessive laryngeal usage. You know, every time you're producing a glottal production, every time there is a backing, there is excessive laryngeal usage there. And the other thing is, people with cleft, as I told you, tend to lose air pressure at the level of velopharyngeal port. So to compensate for that also, they sometimes overuse their laryngeal system, which can also result in problems in loudness and quality. So it sometimes can be as bad as this.
Made lemon jam. Put the baby in the buggy. Kindly give cake the cake. Go get the wagon for the girl.
But most oftentimes what we have seen is if you identify the compensatory patterns early and work on them early enough, these voice problems can be prevented in individuals with cleft lip and palate. The next parameter is speech understandability and speech acceptability. I think for want of time, I will skip these two parameters. These are parameters that you rate listening to the overall speech, and you say how much you're able to understand the person's production and how much natural is it sounding to you. That's what we do when we are looking at rating speech understandability and speech acceptability. I will just skip this for want of time now. So on the whole, when we do a perceptual evaluation, what we need to do is profile the speech characteristics in terms of each one of these domains. All of this domain is important. You cannot skip any one of these. And when you're doing your perceptual assessment, if you're really doing it in a systematic way and in a meaningful and reliable way, that will give you indications for the need for any further assessment. So it's with perceptual evaluation, we decide that should this person go in for any further assessment for velopharyngeal dysfunction? Is there a need for instrumental assessment? That is determined based on how we do the perceptual evaluation. And instrumental evaluations are generally only required when you want to confirm the presence of velopharyngeal dysfunction. For none other condition in cleft lip and palate is an instrumental evaluation very, very essential. It is therefore, there is a lot of importance to our ears. There is a lot of importance to our trained ears. And that's why the speech pathologist forms such a vital part in the team. And if a perceptual evaluation is done in a systematic and comprehensive manner, this will help us set the objectives for therapy. So just based on a transcript itself, we will be able to set appropriate objectives for therapy. So in conclusion, I would like to say that perceptual evaluation is the gold standard. And when we are doing perceptual speech evaluation, it's important that we have appropriate speech stimuli, use proper reporting parameters, and make sure our ears are calibrated so that the results that we are giving are reliable and valid. Perceptual evaluation guides or indicates necessity for further instrumental evaluation and assists in setting objectives for therapy. Thank you. If there are questions, we can take up.
Thank you, Dr. Savita. That was very comprehensive and absolutely engaging. In fact, it's ignited that urge to learn more about cleft lip and palate for us who are not even into that field. So thank you so much. Ms. Disha will be taking over the questions now. So if you'll have questions, please kindly put it into the chat box.
Yes, ma'am. There are a lot of questions. Ma'am, shall I start with first question now?
Yes.
Okay. So, are the speech motors milestones are delayed in CLP kids less than 1 year of age?
Speech, when you look at when you look into the patterns, when you look into the speech patterns, babbling in terms of speech production, yes, babbling is definitely affected in individuals with cleft lip and palate. If you're talking of the other vegetative movements and other vegetative things, there can be a slight impairment because of the defect that is there per se, but they develop compensatory mechanisms beautifully. So, there can be certain delay that we notice in terms of certain skills, but they do catch up and have compensatory mechanisms for them. In terms of speech production per se, definitely babbling is delayed, and the repertoire during babbling is also very, very restricted in individuals with cleft lip and palate.
As a private practitioner's viewpoint, I would like to ask, how is the placement of mic important? And secondary, can we use phone? Because not everybody has a recorder, and large number of CLP cases. So can we use phone as recording the speech sample? Will it be still valid in assessing the speech samples?
Yeah, these days there are a lot of phones with good quality microphones, so you can definitely use them. But you got to be careful in terms of the ambience in which you're recording. What is very, very important is you avoid rooms which are noisy, and equally important, you avoid rooms which are reverberant. Both of this will have to be avoided. Placement of mic is very important in order to get a good sample. You place them at an appropriate distance of not more than 10 to 15 centimeters away from the mouth, and place them at an angle so that there is not much of air noise that is getting picked up during the recording. So all those general strategies for a good recording that we use for any sample applies even for cleft lip and palate. And whether mobile... Sorry
to interrupt in between. What about your speech disability percentage? Will it be? It will be changing before and after the surgery, right? So
definitely.
How are we going to mention that part? Which one to be taken into consideration?
It is definitely the one post-surgery that has to be taken into consideration. And we recommend a period of at least 1.5 months after surgery to do the evaluation.
And is there any effect of fistula based on its position and the size on speech outcomes?
The size of the fistula generally does not matter, but the position is very, very important. Even a tiny fistula in a critical position can cause a big effect than, a large fistula in a place where there aren't many speech sounds that are produced. So the position of the fistula is important, and generally what happens is sounds that are produced posterior to the, sounds that are produced anterior to the fistula or at the level of the fistula are affected in case of individuals with cleft.
This suggestion from Subramaniam sir, that we can put phone on mute or aeroplane mode so that it does not disturb in between the recording when we are using phone.
Yeah.
Okay. So
sure. Yes. That's definitely a valid thing that has to be kept in mind. Yeah.
There's one more question.
So that your notifications and all of that does not affect the recording. Yes. Thank you, Subbu, for that.
So one more question, ma'am. If the person is using prosthesis, then while calculating disability percentage, should it be done with or without prosthesis?
I think, no, the prosthesis is always a temporary fix there. It's not a permanent solution. So it's better that you do the calculation without the prosthesis.
I have a question from my end also. So there's a kid of age 5-year-old, cleft palate. Then the kid is having hypernasality.
Okay.
And she has a severe tonsils as well, tonsillitis as well. And she's a kid with unilateral hearing loss.
Mm-hmm.
If we don't treat the tonsil, she still, there are chances of getting more recurrent otitis media also, because she keep getting cold.
Okay.
So should we be treating tonsils first, or should we be considering BPI? Because if you remove the tonsil, again, your pharyngeal space is going to increase. So that's going to increase your hypernasality. So which one should be taken care of first and why?
Okay, considering that this is a child who is having tonsils and still presenting with hypernasal speech, it means that there is a possibility for velopharyngeal dysfunction, and that velopharyngeal dysfunction will have to be treated surgically. Now, if the tonsils is causing recurrent issues and the tonsils needs to be taken care of, then it's better to take the opinion of the medical, of the ENT there and take a call on the tonsils. And if that needs to be operated, it's better to work on that and then look into BPD. Because you're saying, despite the tonsils, there is hypernasal.
There's hypernasality, yes.
So which means, in spite of having a compensation there, this person is not able to compensate. That means there's a very clear-cut evidence that there is velopharyngeal dysfunction. And in such instances, for this case, I would say, because there are medical issues that are contributed because of the tonsillitis, you take care of that and then follow up again for the velopharyngeal dysfunction. The severity might definitely increase. Yes, if you're perceiving a moderate hypernasal resonance now, post-tonsillectomy, you will find that it could be a hypernasal resonance, or it could remain the same as well. It's not mandatory that it has to become severe. It could remain the same as well. And then you can take care of the velopharyngeal dysfunction.
There's one more question on the in continuation of prosthesis, that this is in continuation with the question on prosthesis. The person is an adult and is using speech obturator for more than 5 years. Is there a chance for repair of a fistula in the hard palate? And she also has unrepaired soft palate.
Has unrepaired soft palate and a fistula in the hard palate. Can you just clarify that? You're saying there is a fistula in the hard palate and the soft palate is also unrepaired, and this is an adult.
Yes. And she's using a speech obturator for more than 5 years.
We will have to probe into to see why she was on a prosthesis for all these years. But if medically she is found to be fit, if she has no vascular disorders or anything because of which surgery has not been, I mean, we need to see why surgery was not done all these years. But if proven medically fit, definitely she can undergo surgery. Even though she is an adult, if your question is, since she's an adult who has used prosthesis for 5 years, should that be an inhibitory factor for going in for further surgery? That need not be an inhibitory factor for further surgery. I think I have a frozen screen for Disha. Zainab, you're on mute.
Yeah, she's back. Yeah, Disha? Yes.
Yes, just 1 second, ma'am. There are lots of questions coming in. I just have to see.
I had a question.
Yes, please.
In adults or, prolonged, they have glottal stops. Has there been any rare case where you have seen someone with nodules along with, because of consistent use? So what happens? Okay.
So unless you correct the glottal stop, you can't do anything about the nodules because it's a glottal stop that's contributing to the abusive behavior there. So we need to first look at eliminating those glottal stops.
Okay. So what would be the course of therapy in such a?
We will have to identify one because it's an adult. First thing is the adult motivated for therapy? That's the first important factor that we need to take into consideration, because as far as adults are concerned, unless they need the change or they are seeking for a change, we may be the best therapists. I don't think we can bring about a change in those instances where they don't want to bring about a change in their speech. So that would be the first factor we need to consider. Then the next thing would be a profiling in terms of trying to identify what are the speech sounds where there is a glottal production that is happening. Even if we are able to identify one sound without a glottal stop, we can try to use the facilitatory approach to see whether we can move gradually to the other sounds from the sound which he or she is producing without glottal stop. If it is glottal stops for all the sounds, then it's definitely a difficult task ahead, but we can start with trying for the bilabials before we try on to the lingual consonants.
So, and somewhat similar for children also?
Definitely, yes, yes, yeah.
Thank you.
In the recent days, there has actually been a reduction in the amount of individuals we see with voice problems because interventions are actually happening much earlier these days. A few years back, maybe 10, 15 years back, surgeries were happening at a much later age. So we had lots of individuals with glottal productions. Today, I would say with early intervention and with early management, the number of individuals who result with glottal productions, especially when managed in the typical age range, are much lesser because we are able to correct those patterns much early. So therefore, people resulting with voice problems and all of that is less. But yes, as you say, we can see them in adults who have never attended therapy sometimes, and they come into clinics only at a later age. There, such kind of presentations are quite common.
Thank you.
So, ma'am, one more question. If the patient is having malocclusion or any other dental issues, so are we supposed to wait for their dental treatment to be completed, or can we start along with the can we start therapy for the same patient along with the dental treatment?
Depends on what sounds we want to work with. If you want to work with the dentoalveolar sounds, then I would say you will have to wait. But if the same patient is also having a glottal substitution for velars, those are definitely sounds that can be worked on. So the answer to this question will depend on what is the profile that we see. So there are certain error patterns which can still be corrected despite having dental abnormalities. But when the dentition is contributing to that error pattern, then those sounds will not be worked upon. So that's the crux there. So a person with cleft can have a combination of compensatory and obligatory errors. Differentiate between them. You can work on the compensatory at any point of time, but not on the obligatory ones.
So if shall we ask more questions or?
Are you asking me?
Yeah, yeah.
I'm okay to take more questions.
Because there's still a question coming. Ma'am, one more thing I wanted to ask. So when we record a speech sample and whatever may be the reason due to our unknown, not able to identify the errors, what if we miss on those obligatory errors and we just label them with the placement errors?
I would say when you're working on therapy, monitor. Any speech therapy should bring about a change in a matter of 6 to 8 sessions. You're working on an objective with your right techniques for 6 to 8 sessions, and you're still not able to bring about a change. Introspect. Look in and see why is it that the speech behavior is not changing. It could be that you have targeted an obligatory error. So at least there, it can ring a bell and you can go back.
This change should we expect at a syllable level, word level, or in general, we should expect the change?
It depends. For some of them, you'll be able to move on to the word level. For some of them, it might be only at the syllable level. But some change you should be able to perceive.
So I think rest of the questions can be mailed to ma'am as well.
Sure.
First of all, I would like to thank you, ma'am, for giving us such an insight and interesting view in this topic. I am sure everybody is going to analyze speech sample in their sleep also today. So thank you for being such a wonderful speaker. And I thank you all the participants for being such a patient listener. Most importantly, I would like to thank Isha for their technical support, Shweta ma'am for the same. And last but not the least, Isha SIG team for their support and team efforts. Thank you, everyone.
Yeah, thank you, Disha and Zainab for beautifully conducting this session, and big thanks to Isha SIG on Speech Private Practice for this opportunity. It has been a wonderful evening. Thanks.
Thank you so much. Thank you.